kind of leads into a description of, okay, what are the common things, what should we describe? What practice entities we should describe? And it was a thought processes, probably about 80% of the time we're treating maybe between 15 and 20 conditions in our practices. And so it's like, let's pick off those and let's define that. And the easy way to describe that or to come up with that is to appoint leaders in each area. And within the orthopedic world, orthopedic physical therapy world, we're kind of simple. We do things by body regions. You're a foot nerd, you're a shoulder expert, you're a back spine guy or gal. And so we took the leaders from each of those body regions, the leaders of clinicians that were also publishers. So the Josh Cleveland and John Childs for the neck, and Rob Weiner was in that group. We had Tim Flynn, Tony DeLito for the thoracic spine and low back area. We had Phil McClure for the shoulder, and Joy McDermott for the elbow, wrist, and hand. So then when it came to the hip, it was very easy to get some leaders, Mike Shabolka and Doug White, and for the knee, Lynn Schneider-Mackler at University of Delaware, and for the ankle and foot, we had Tom McPoyle and Rob Roy Martin. So it was that group, and then we gave those leaders marching orders. And the marching orders were go select people that could help you, that were also rounded out the teams for each of those areas. So that 3, 4, 5 different individuals, and the marching orders will also include a physician that was prominent in that area. One of our physician leaders has been Paul Shakel, who's been really helped us also with our methods, and he's been a big support with kind of gearing us towards here's what it takes to put practice guidelines together to fit the different needs. Each of those work groups named off and have decided which guidelines to create. It was a lot easier, for example, in the extremities, and I'm in the middle of working with the shoulder group for the practice guideline that we're working on now on adhesive capsulitis, frozen shoulder. But if you think about shoulder, there's going to be those areas where you get stiff, the adhesive capsulitis, like I mentioned. You also have the rotator cuff syndrome. You have that area, and you also have the instabilities, the post-dislocation individuals, the sprain, strains crew. So that's going to be the 3 areas for sure that they're going to have. And it's the same thing you could say for the knee. If you looked at, Lynn Schneider-Mackler and her group, of course, they did the knee ligament strains, and they also did one on the articular cartilage problems for the meniscal problems. And they're toying with, okay, do we do OA next? We partner with the American Academy of Orthopedic Surgeries with OA because there's recently that one, or do we do patellofemoral pain next? And so they're playing with that. And so they're basically the different guidelines. The foot and ankle crew is very easy. Hey, we've got the plantar fasciitis, we've got Achilles tendinopathies, and we've got ankle sprains. So if we do that, we cover a lot. The elbow, wrist, and hand, boy, tennis elbow, epicondylitis, slam dunk. Oh, carpal tunnel, slam dunk. So we'll do those, and then we'll see if we want to do more. And so low back and neck pain, well, the hip was also, I could speak, that was the hip OA is a big thing. So we did the practice guideline in that, and that was very well received. And now they're we have a draft of a non-articular hip disorder, so the labral tear, those type of things. And they'll probably do one on hip fractures because it's such a common issue that we have to deal with as far as for rehab of that in our different scenarios from outpatient to inpatient. For low back and for neck, it was very interesting because if you think of our guidelines, we've linked the ICF term or the ICF impairment of body function, so a mobility deficit, a coordination impairment, power deficit, stiffness, endurance. We linked those impairments with the IC, so the ICF label for those impairments with the ICD label for the disease condition, pathology. And so for the spine, that was a little harder because the ICD labels were not real descriptive, such as lumbago or cervicalgia or headache. So you didn't have the links like you have in the shoulder with adhesive capsulitis and supraspinatus tendonitis, rotator cuff syndrome, or ligament sprain instability. Same thing with the knee and ankle and foot. So the guidelines have been more global with neck pain, as you see, and now we're in the middle of low back pain, and they've been more global of encompassing impairment strategies and classifications that are out there and putting in a common language so then we can all communicate very easily with that. So that's where it wasn't as differentiated as the known pathologies you have in extremities, because with low back and neck pain, the actual pathology isn't always very known. So we went with more global terms as far as neck pain and low back pain for those guidelines. So in the end, we'll probably end up with about 15, maybe 16 of those of the guidelines that'll encompass, and then that'll probably be enough, because by the time we finish those 15 or 16, 5 years will be done, and then we'll be doing revisions of the one we've done just to keep them up to date. So we'll probably just keep in that strategy. And we also probably partner with maybe other sections, such as the hand section, to work with the elbow, wrist, and hand. So it'll be a shared responsibility, just a shared effort with that. So that's a little bit exciting on that account. Just like we might partner with the American Academy of Orthopaedic Surgery for the knee OA guideline, because they recently have done it. So we'll have that partnership, and so that's where we'll be heading with our future development. First is our advisory panel for our level of reviewer content. The second level is our stakeholder groups from some of our physicians, like Dr. Paul Schickel we mentioned, but also Dr. Altman, who's an editor of Archives of Physical Medicine, to claims reviewers, to academic physical therapists working in the academic world, physical therapists working in the clinician world, physical therapists working in a residency program of both orthopedic and sports. And so we have that, so we get the input from all different constituents there. And for each practice guideline, we also have a content expert review panel. So it's been, so for example, as an example for the Achilles tendonitis, Achilles tendinopathy, we had Jim Zakaszewski, who's a real prominent sports physical therapist, and review it with related to that. We had Sandy Kerwin, who's really the scientist, basic science researcher that's published a lot, so she reviewed it. We had Tom McPoyle, because he wasn't an author, so he was a reviewer of looking at that, who's an academic researcher and really knows the literature. And then Steve Reichel, who's a clinician, looking at it from the clinical bent, that has a little bit of background with recombinant research. So we had them doing the first review of the content, but then we also used our other constituents for the overall review. And the same approach is happening in low back pain. We have a very extensive content expert review from Shirley Sarman to Stuart McGill to Peter O'Sullivan to Dave Butler to Mark Wernicke to Stanley Paris, stakeholders from different aspects of low back care that were really serving the content. And typically we have that group to make sure our literature review is accurate and that we're stating our recommendations are really crisp and right on and clearly reflect the evidence in the scientific literature. And then, so that's one view, and then we have, of course, our other group that we mentioned, like the different stakeholders of the claims reviewers and academic and residency programs. But then the overall, the final product, actually, I'll say what really drives the standard and the consistency is our editorial board from the JOSPT, and mainly Steve Allison and Guy Simoneau. They've been the standard, is like everyone prepares for, okay, you got to do it right because it's not going to pass the muster of Dr. Ellison or Dr. Simoneau, and so there are keeping it to JOSPT standards. So that's the review process as we go through, and that's essentially my role, is to coordinate the driving of the creation of the manuscripts and then coordinate the review process through these different levels of review and preparing it for Guy and Steve at JOSPT. That's, I guess, another part of my job has been to create this revision process. Bottom line, practice guideline is good for about 5 years, and then it needs to be revised. And so so the first guideline that will be revised, our first guideline was the plantar fasciitis, heel pain guideline. So that'll be the first up for review. Part of the idea when we created the work groups was to have somebody that's going to be excited 5 years from now to head the revision process. And so when we created our work groups, initial work groups, we had that in mind. The process in place is to actually have a revisions coordinator, so not just the ICF Practice Guidelines Coordinator, but the ICF Practice Guidelines Revision Coordinator. So it'll be take these groups through this revision process. And it's a bit evolving, but the idea is that we're just not going to republish the 12 or 15 pages of the guidelines, but it'll probably, and this is how it's looking, I mean, it'll evolve as we go, but look at the maybe 3 or 4 or 5 really critical publications in the evidence, in the scientific literature that have really updated and changed, and with those, relatively small amount of articles and these different things. I mean, I'm guessing 4 or 5 or so. Take them through the grade process, which is a process of actually critically appraising the quality of those journals, publications that have updated the literature, and then incorporate that into the recommendations. So there'll be a bit more of a concise summary of the guideline and not a restatement. Updates can be put on our orthopedic.org website, or so we can create changes on the fly, so to speak, or improvements, and then have that be put out for public information. The nice thing about rehabilitation, it's a little more stable than you'd say, than maybe, for example, a great drug came out. It's like, oh, it's really changing care for cardiovascular disease or something like that. Well, you really can't wait for 5 years I think that there's the changes in rehabilitation are probably a little more subtle than that, and also with our guidelines where we've had, and what will probably change is maybe the strength of the recommendation. We had a little bit of evidence, and so it's, like a mild or, with not so strong recommendation, we'll probably move to maybe a different one, or even conflicting evidence, as the literature is published.